Good morning.
How are you?
I am great. How are you?
I'm good. I'm confused right now. Okay.
Oh,
I was like, I have my do not disturb on, but I'm getting notifications. What is going on? Ah, all right. We are here. Good morning. Good morning, everybody. Good
good
morning.
morning.
Our on the scene correspondent over here. Good morning. All
Good
right.
morning, crafty coder.
Good morning. Good morning. Happy Saturday. Happy Saturday, Renita. How are you? All right, Mr.
Hey, Renita.
Jesse, you sound low, but I don't know if it's just me. Oh, it
Good.
might just be me. Never mind.
Okay.
Okay. I don't have my equipment because I have I have a line dance engagement to this today. So I don't have my equipment here. So we're not on Clubhouse at all.
Okay.
All right. All right. Well, let's get this party started. Because this party, woo, mm. Things are going on out here in these streets. So, welcome, welcome everyone to the Saturday morning tea. Wait. I'm doing something wrong here. Okay, let's do that again. Okay. Uh oh. Okay, welcome everyone to the Saturday morning tea where we discuss uh all kinds of stuff. We discuss health information, news, education, certification tips, entrepreneurship, um, the OIG, compliance matters, just the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, the heart of it all, that specializes in revenue cycle and regulatory compliance in education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Do you really? Well, before I introduce my co host, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Yes. I'm reading comments and chuckling. If you are interested in uh, getting more information about the 5 steps to become a certified marketable medical coder, then check out the video description for the link. Yeah, it's a lot of stuff in there, but that video, that link is right there in the description box. So, joining me today is my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Yes. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse.
Whoa, what did you do?
Oh, what happened? Am I
You sound
loud?
staticky or something.
Oh,
And you were
you
fine
know,
before.
ask the crafty coder how's my audio.
Wait,
Crafty coder, how am I?
we waiting on her. In the meantime, good morning, Vicky.
Because it could be, you know what? Let me,
Okay, you
let's,
sound fine right now. She said choppy.
oh, how about now?
Much better.
It's those
I know.
It's
Look, I had to plug in.
yeah, that's what I'm gonna get ready. All right, how about now?
Excellent. Yay.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been an LPN for a very, very long time. In 2014, I transitioned to the wonderful world of HIM, and in 2020, I created a company, The Coding Nurse, where I help nurses and other healthcare practitioners with clinical experience to transition into the wonderful world of HIM like I did.
All right. All right. Look at you helping the community.
Yes. Somebody
And
has to
all of
do
these
it.
things. If not you, then who?
Hey,
If
how
not
about
now, then when? I love it. I love it. All right. So here, I'm chuckling about the crafty coder. I need to come up there for a tutorial. I can't even do the bus stop. Don't pull my car. Ma'am. Well, you can
But you know,
follow me. I have the YouTube channel with the tutorials, and then I also have a online course. So you are more than welcome to come through. We can talk later. Go ahead, Mr. Jess.
but those dances are really regional, and they kind of almost mean the same thing, but
They
they do it
are
a little differently because like everybody knows like Chicago's known for stepping, but actually
correct.
here in Philly they call it the bop. It's the
Okay.
exact same thing.
Okay, the Bob. All right.
Mm-hmm.
Yes. Well, they have we done just totally went off course, but they have they have national conventions. They have meetups and conventions and the whole thing. It's a whole vibe. It's a whole vibe.
I could
Okay.
believe it.
Now, on to the business at hand. Um, so before we jump in, again, let me remind you that this is a conversation and we want your opinion. We want to know what your thoughts are related to the topics that we bring today. So feel free to add in the conversation, place your comments and questions in the chat. Your opinion matters here and is welcomed here. If you have a question, just make sure you put a Q first so that we know it is a question for us and we don't miss it. Right, all right. So, for those who are joining us today or just watching the replay, today we're going to talk a little bit about more about AI and the health information profession. This stuff is just, I don't know. It's just, it's overwhelming at times. But there's a lot of discussion. There's a lot of conversation. And we want to make sure that you are abreast of what is happening as it relates to that. But before we get into all of those, it is time for our church announcements. Yes. Always got to have MLK. Always got to have. Keeps the peace. Keeps the peace. Oh. The name of the song is just Sad Sunday. That's sad to me. It's all good.
Mm-hmm.
All good.
All this time I have been focusing on the organ, but it's a mean guitar in there too.
Yes. They're just doing the thing. Okay. Look, we can hear and listen to this all day. All right. So church announcements for today. Recently, the uh, physician fee schedule final rule was released by CMS. And for those background information, it gives you information on policy changes for Medicare payments and other Medicare Part B issues. It goes into effect on January 1st, 2024. I won't go through the entire thing, but there were two things. I'll do a long form video later, but there were two things that just caught my eye. The first one was they are finalizing coding and payment changes to better account for resources involved in furnishing patient-centered care involving a multidisciplinary team or clinical staff and other auxiliary personnel. So these finalized services are aligned with HHS's Social Determinants of Health Action Plan and help implement the Biden-Harris cancer moonshot goal of every American with cancer access to covered patient navigation services. So specifically, what they are doing is they are finalizing to pay separately for three items: community health integration, social determinants of health risk assessment, and the principal illness navigation services. So I want to jump down to the social determinants of health because that's the one that caught my eye. So they are finalizing both coding and payment for a social determinants of health risk assessment, which would recognize when practitioners spend time and resources assessing social determinants of health that may be impacting their ability to treat the patient. They're also finalizing the addition of the social determinants of health risk assessment to the annual wellness visit as an optional additional element with an additional payment and no patient coinsurance or deductible when it is provided with the annual wellness visit. So they are finalizing codes and payment for social determinants of health risk assessments furnished with an evaluation and management or behavioral health visit. What you think about that? I knew it took some money. It was going to take some money to get this off the ground.
It's just there's always a work in progress. There's always something like you could. I guess we'll never get to. There will never ever be a point in healthcare where you can just be where there's nothing going on, because I guess this is under the moniker of continuing improvement. I don't know, but
Well, every
we'll see.
administration has something.
Yeah,
So, yeah.
we'll
They
see.
have something. They have something. But we've talked about the social determinants of health before and the reluctance of providers to actually document and apply the appropriate ICD-10 codes for social determinants of health. So I guess uh, putting together this payment model for on the Part B side or the physician side now gives an incentive, if you will, for them to actually do it. The other thing, which was a very, very good thing, um, uh, was that under behavioral health services, so there's a few things under there. They are going to allow or provide or allow the services of marriage and family therapists and mental health counselors to receive Medicare Part B coverage and payment under the Medicare physician fee schedule for behavioral health services. Additionally, they are finalizing their proposal to allow addiction counselors or drug and alcohol counselors who meet the applicable requirements to be considered a mental health counselor or MHC. and to enroll in Medicare as MHCs. So MFTs, which are the marriage and family therapists, and MHCs, which are mental health counselors, will be able to begin submitting Medicare enrollment applications after calendar year 2024 physician fee schedule final rule is issued, and they will be able to bill Medicare for services starting January 1, 2024, consistent with their state statute. They're also making corresponding changes to behavioral health integration codes to allow the MFTs and MHCs to bill for these services as well. I was like, this is a game changer right here. um, because they were not allowed. It was only clinical psychologists or physicians. And so all I can hear is the scope creep stuff rearing its ugly head in my ear. But this was a game changer. So for those of you who, and I believe it mentioned the criteria for these counselors, and I want to say they're master level folks who have their master's degree and or doctorate degree, and also meet their state requirements for licensure. So this is a game changer. I was excited about that. So more to come on that. Mr. Jesse, you have any comments on that?
It will be interesting to see if, like you have mentioned, the scope creep. It'll be interesting to see if these physicians or whomever have an issue with that. And honestly, I don't think they will, because the people who they are proposing to allow to bill, they're servicing the people that they don't want to deal with anyway.
Right. And they are allowed to bill at the state level. They just were not necessarily allowed to bill for certain services. There's certain state services, of course, it's wide open, but there were certain services that Medicare did not recognize for them. And so they're opening the doors for that. So yeah, I thought the same thing. Let's see. Oh wait, we got the usher finger. Right. Patient be homeless, no electricity, and no mention of it in the note. Right. And again, that's a because of that situation, there are challenges in providing optimal care to that patient. And so documenting that information and coding for that information, I won't say it's a win-win, because of course, if you're in that situation, that is not a win-win, but it allows you to take the time to then assist that patient with resources that may be available to them that they may not have known about, or help that you can provide to them because of their situation. But then the provider who is taking the time to do all that now is compensated. So maybe they'll give extra special care, I don't know, in doing those things for them versus pushing them out the door, on that hamster wheel. Just, move on. We got a production quota to meet, so they won't give the time for that. She said, yes, go ahead, MHCs and MFTs. That's awesome. I am so excited about that. I am hyped up about that, especially for my clients, because we about to do it all. Okay. So those were my church announcements for the day. I don't know if anybody else had any church announcements. You could let me know. Mr. Jesse, did you have any?
No
church announcements. Okay. I'll be looking in the comments and see if there are any additional church announcements out here in these streets. Looks like none. Okay. Hearing none, I'll move to the next topic. I feel like I'm Oh, I do have a question. Let's see. She says, where do we find the incentive for the determinants? You would look in the 2024 physician fee schedule final rule. It's on CMS's page, or you can do a Google search. and look for the actual rule. They have summaries, but the actual final rule gives all the details. All right. So today, well, there was another thing, but we'll talk about that later. Okay, so today I want to talk about a workforce study that AHIMA released. They released this week, dealing with AI, and it was a survey, the results of a survey on workforce challenges and the role of emerging technologies, i.e., AI. and then, and then I want to also kind of bring up someone in the field who's been in medical coding for decades and get her opinion. She also penned an article related to her thoughts on AI. So I want to take a look at that as well. So let me share my screen. I learned something new and now, okay. Okay, it worked. Oh, I'm excited. There we go. Okay. So here is the report, final report. Oh, they tried to play that CMS thing. Okay, the final report on this information. And a couple things. It's a lengthy report. We will not go through all of this, but there were a few things I wanted to mention. Where did it go? Okay. So the methods, that's always important as a yeah, that's always important. So they distribute, so from August 8th through the 22nd of this year, they fielded a 10-minute, 31-question web survey that was distributed via Qualtrics to 35,519 health information professionals. As an incentive for participation, respondents were given the option to be entered into a raffle for gift cards. Survey recipients occupied a range of health information roles, including privacy and compliance, data quality, data analytics, revenue cycle management, and consumer health information. Of the 35,519 AHIMA members that received the invitation, 5,516 opened the survey instrument. And then they had some screening questions on whether they had supervisory and or hiring responsibilities at their organization. Among those individuals who began the survey, 2,526 met the screening requirements and were eligible to complete the survey. So this is the results of those 2,500 of or so folks who completed their survey. So what they learned from the information was that there were understaffing in, I think we all know this, in the health information workforce. 66% said they experienced understaffing in the last 2 years. 34% said they did not experience understaffing. Of course, they are attributing some of this understaffing to the pandemic, because they stated that folks mentioned the pandemic worsened their staff workload, along with competition with other organizations for talent and access to talent. Impacts of COVID. Again, staff, they said that in 4 out of 5 workforce challenges categories, a greater proportion of respondents indicated that COVID-19 worsened their respective challenge rather than improved. Worsened staff workload, competition, access to talent, organizational funding for health information, staff, and resources. And then neither improved or worsened were organizational leadership respect for the contributions of HR professionals. Okay, already. Wow. All right. Next, challenges for recruiting. They had local pay constraints, salaries are not competitive within the local market, limited local talent pool. When can I make this a little bigger? Okay, limited local talent pool, national pay constraints. Organization cannot compete with salaries offered through remote positions in other parts of the country. And then also at 51%, lack of experience. Available candidates do not have the work experience to adequately fill available roles at the levels needed. 44%, lack of expertise available. Candidates do not have the necessary skills or training to adequately fill roles at the levels needed. 43%, candidates prefer remote work that is not offered with available positions. And then organizational resource challenges and constraints came in at 33%. Other organizational actions that they use to improve recruitment, 45% said they increased pay. 40% said they increased the number of staff that can work remotely. 28% said they increased on-the-job training opportunities. 22% increased reliance on automation and machine learning products and services. Keep that one right there, top of mind. 20% said they did nothing. 17% lowered qualifications, or removed certification requirements for certain positions. Keep that one too. 15% business process outsourcing. 5% increased funding for offsite training, and 4% reduced the workload. The impacts of understaffing, 76% employee burnout or staff dissatisfaction, 48% high turnover rate, 48% decreased reimbursement, slower claims processing, and increased claims denials, 37% lower data quality, 36% slower release of information, 19% slowed implementation of regulatory requirements, 14% privacy errors, decreased patient privacy protection, 7% decreased patient safety, and 6% said none. So as they talked about the burnout and all of the things here, Mr. Jesse, did you want to jump in?
No, I'll wait till we finish.
Okay. So driver of this professional health information professional turnover, 47% said low pay, 28% said employee burnout, 21% lack of flexibility for remote or hybrid positions, 15% lack of support for health information positions from organizational leadership, and 10% lack of training or professional development opportunities. And this is when considering each driver of turnover, respondents ranked each factor individually from the most impactful to the least impactful. And then their actions, again, with the increased pay, increased number of staff that can work remotely, increased on-the-job training opportunities, none, increased reliance on automation and machine learning products and services. It's where my keys are. Unfilled areas, role areas. You have data quality. So they're saying 62% are unfilled, with clinical documentation improvement, quality assurance auditors, coding auditors and educators, medical coders, master patient index specialists, and disease registry registrars. 40% in consumer health information, which would include patient service representatives, community health workers, patient navigators, and medical record clerks. I don't, what is that? Does that still exist? Okay. 40%, 40% revenue cycle management, directors of revenue cycle management, revenue integrity specialists and analysts, charge master analysts and medical billers, privacy, risk and compliance managers, privacy analysts, privacy officers, or directors of health information management. That's at 20%. I didn't say the percent. Revenue cycle management and consumer health information were tied for 40%. And then bringing up the rear, 19% data analytics, clinical researchers, clinical data managers, and health data analysts. This was on the discussion of lower data quality, slower release of information, implementation of regulatory requirements, patient privacy and safety. And these were the other areas that. So preparing for increased uptake of advanced technologies. Nearly 45% of respondents reported that their organization uses artificial intelligence or machine learning tools for coding, documentation, or other health information related workflows. Use of AI or ML was higher in urban and suburban settings compared to rural settings. And then smaller workplaces with 1 to 25 health information professionals were also less likely to use AI or ML compared to over half of the respondents from larger organization sizes with over 100 HR professionals. Now, I know they pointed out, this is where the data piece, depending on where you lean and what you focus on. So they're telling you about 45%, but it says 55% are not using it. So, okay. I just want to point that out. For those who are not using it, the reasons why, they said lack of funding to purchase technology at 45%. 41% said technology does not fit within their workflow. 39% lack of organizational policy, governance framework to implement technology. 27% lack of and or perceived lack of accuracy with the technology. 20% ethical concerns about the development and or use of such technology. And those who are using, they use at 83% computer assisted coding, 26% algorithms for patient matching, 20% administrative workflow assistance, 19% autonomous coding. That's what we talked about last week. 15% healthcare utilization management, 12% AI risk adjustment, and then 8% chatbots such as ChatGPT. So here were some potential benefits and challenges of AI or ML. Benefits: alleviates staff burnout or overwork, reduces administrative burden, improve productivity, reduces staff headcount, reduces departmental expenses, decreases claim denials, improve compliance, increase patient safety, and improve data quality. Challenges: reduces data quality, increase claims denial, increase errors, increase costs, increase technical burden, increased oversight, need for more quality assurance, increased regulatory reporting burden, lack of skilled workforce, and real or perceived bias issues. I think that's it. Now they just go into breaking those things down. So yeah, so in the impact of AI or ML on HI jobs over the next 5 years, they believe that there will be a 20% increase, a 40% decrease, and 40% of no impact. So that's going to be interesting to see what that looks like over the next 5 years. Next steps for the health information profession. 75% believes they need to upskill the current workforce. 72% new training or focus area for future workforce. 68% increase awareness of health information professionals' value among healthcare leaders or and executives. 51% more input on development of new technologies, 43% increased need for more data stewardship, and 42% more stringent privacy, and or compliance process and protocols. All right. And then so this was interesting. Federal funding for upskilling programs. So they feel like that the Office of the National Coordinator for Health Information Technology and which is the ONC, and HRSA, Health Resources and Services Administration, should have health information professionals, providers, payer, and data technology convention, or they should get all of those folks together to develop a rapid upskilling program curriculum to be deployed and supported online and or at the state and local level. This would be developed as a full module in the ONC's Health IT curriculum resources for educators, dedicated to training best practices and guidance for using different AI and ML tools. Of course, supported by federal funding, this curriculum could be circulated nationally and adapted at the state and local level and or at healthcare organizations as a training and upskilling program. This curriculum could also be integrated into current certification, graduate, and undergraduate health information programs. I thought that was interesting as well. Okay, and so here's the conclusion and limitations. All right, Mr. Jesse.
Well, that was a lot. I don't know where you want to start. Because I just feel a whole lot of ways, because from my key takeaways are, if you want to improve health information, you need to get rid of gatekeeping and pay some more money.
Well, they didn't even need the whole 2,500 people for that one, did
They
they?
really didn't. They could have just asked me.
Who paid for this one? How much did it cost?
Because it was curious. I'm not surprised, but it's like people don't even realize, like, they really act like it's a problem, but it's a problem they've created. Like, at the top of the list, the highest shortage is in CDI, but that's like one of the most gate-kept professions in HIM. And you wonder why?
Because we got two gatekeeping organizations that are together. Two gatekeeping professions that are involved in CDI work. So interesting.
I mean, but I was surprised at the amount of people who don't believe that AI is going to affect things in the future.
Yeah. Yeah, she said, we got some snaps. Miss Renita, snap. Miss Vicky said, exactly. Crafty Coder says, my problem was short staff. It's a bunch of coders out here. Now, there is a difference if you mean lack of skill versus lack of coders. Yeah, and we talked about that. The math, not math then. Like, you have all these people who are certified, who have experience, and then you have all of these positions, and for some reason there's not a love connection. And why? Why? That's probably part of some research that needs to be done, and some further digging to understand, well, what does that mean? What is that all about? That's the thing. Okay. Well, here we have information from, I did something wrong. Oh, Shift S. Okay. It didn't do it. I don't know why. Okay, never mind. Maybe I only get to do it one time. Here's some information from an article from Gail Smith. She was one of my instructors years ago when I got my associates in health information technology. way back in the day. But anyway, she wrote an article, AI and Coding, Can It Reduce Cognitive Overload? And so she talks about, how, let me see if I can make this a little bigger. She talks about medical coding is complex and time consuming. The process is complicated by pair specific billing rules, coding guidelines, and translating complicated clinical documentation into 3 distinct coding systems. That is a whole lot and a mouthful, because that's all the things that we do. ICD-10, ICD-10 PCS, CPT, and HCPCS. We use HCPCS as well. Medical coding requires a deeper understanding of the coding systems and the ability to translate clinical documentation. Specialty coding, such as cardiology, orthopedics, and neurology, requires additional in-depth knowledge and specialty-specific terminology, guidelines, and complex coding pathways. So can AI help untangle the complexity of coding systems and reduce cognitive overload? Well, she said, what can AI do? AI is powerful and can revolutionize the coding field. It is important to note that while AI can significantly enhance medical coding processes, it is most effective when used in collaboration with human coding professionals. Human expertise will be essential for handling complex and nuanced cases, resolving discrepancies, and ensuring the AI algorithms continually improve through feedback and validation. There is interest in incorporating AI into our field. A quick literature review unveils many AI applications making big promises. We've seen some here. And here are a few examples of AI use in coding and her thoughts on how much remains to be done. So, automatic assigning of codes. The promise: AI can review EHR documentation and automatically assign appropriate diagnosis and procedure codes. In her opinion, although skeptical, my early review is that AI exceeds my expectations. I believe that the quote simple end quote coding, meaning that those with a short coding pathway would be perfect for AI. However, certain areas will be impossible unless the system is edited closely and trained by coding professionals with advanced knowledge. Coding validation. The promise: AI can verify the accuracy of codes generated by human coders by cross-referencing them with coding guidelines and historical data. It can flag potential errors or inconsistencies for review. Her opinion: real-time editing is powerful if the coding professional has all the tools, such as guidelines and edits, embedded in the process. However, I found inconsistency in application of coding guidelines for the 3 coding systems for the test cases. It is important to note that ChatGPT is not an official coding AI application, but a general language model. Predictive coding suggestions. The promise: the AI algorithms can provide real-time coding suggestions. In her opinion, these suggestions might help coding professionals make more accurate and efficient coding decisions. I am concerned about productivity standards driving coding professionals to accept the suggestions without question. Hmm. Prior authorization. The promise: AI promises to help with coding workflow optimization, such as with the prior authorization process. In her opinion, this has potential to help reduce administrative functions such as prior authorization, obtaining a diagnosis code to support medical necessity for a laboratory test is a real possibility. Now is the time to start thinking about education and training in an AI-powered world. This is a rapidly changing field, one that holds both challenge and promise. So that was from Miss Gail Smith and her opinions. Thoughts, you guys? Thoughts?
I pretty much agree with her opinions, because I think for prior authorization you could use it, because that's that doesn't require a lot of complex guidelines, and that's pretty much just we finding a code to match what it is this person is trying to have done. That's I think that's easy.
Mm-hmm.
But when it comes to coding validation, because I do this every day
Mm-hmm.
at work, it doesn't help.
Mm-mm. And
And it
to her
creates
point
more
about
problems.
production, these productivity standards, they're just pushing them and to her point, so folks will accept whatever it gives and put it on there and push it through, and it's like, but provides more work and more resources on the back end, um, as they're doing that. So, at some point when considering AI for certain tasks within the revenue cycle, you need to look at the entire cycle and its impacts on the entire cycle. And I think what I've seen, or what I've even heard recently, it's siloed. It's creating more silos than not.
Oh, I agree.
Yeah, she said, Crafty Coder, you're not gonna get me in production and pay me $25 at a hospital because AI ain't doing it. Yeah, I don't know. I think similar to the offshoring situation that has occurred, with the promises of being able to get coding done, or that portion of the revenue cycle, coding done cheaper, quicker. Ask some of those folks who've offshore what their opinions are related to that. And I think you may hear some of those same comparisons as it relates to AI today. I mean, folks are like mad scientists trying to put together different codes, like computer codes, not medical coding, but codes and different algorithms and all of the things that are behind the machine to master this. But at the end of the day, today, I don't think it's ready. I don't think it's here now. And I agree with her too about like the smaller things, like I want to say ED, maybe, possibly, but it depends on the cases. Um, some things that you use kind of the charge master for, just maybe validating that kind of stuff. Um, like little small stuff, maybe. But again, to her point, somebody has to validate it though. And you gonna let the machine validate the machine? You don't even let the coder validate, you have somebody else look over and make sure the quality of other coders um happens. So how you gonna do that with the machine without having a person do it?
Well, speaking of validation, it just every week it just boggles my mind because as we all know, like inpatient jobs are always coveted in coding. They always have been.
Mm-hmm.
But what blows my mind is how they they keep people out, but the people who are in ain't up to speed. Because because when did coders stop having to validate codes? Like you just don't code something just because it's documented. Like that's coding 101. Like that's not any high level thinking. That's the basics.
Right.
And I'm just amazed that coders who, and it's not just one, it's all of them. Like and it's because I often ask myself, like, are you even reading the chart, or are you just going by what's documented just to get it done, just by what's coded? Then they want to add, then they want to ask me, the deeper thought-provoking questions that require research. Well, if you coded this chart, you should have the same thing I have, and if you don't, you should know why. Like when I
Right.
look at their codes, I can tell why they have what they have, and I can tell when they go through the computer assisted coding options, they just click them. They don't even validate. It's like it's not this pressure also was not unspecified. If you read the chart, it said it was a stage 2 sacral. So why are you using an unspecified pressure code? It's because you didn't even read the chart.
And that brings up another thing. So say you have a program that is AI generated that does that comparison. And say you have documentation that contradicts itself. Who makes the decision at that point? Or what do they do with those types of situations, circumstances through AI? I mean, are they flagging it? I'm thinking out loud. So like those are some of the things that could come up as well. Because sometimes you have coders that are back and forth, but again, at the end of the day, your documentation is your documentation, and that's what you got to go by. But I wonder how have and these people that are putting together like these, because there that one company that supposedly, word on the street, AHEMA has invested in, NYM is an AI company that is um, pushing autonomous coding to and making all kinds of promises. Um, and so I'm curious as to how that works. What does that look like from that perspective?
Oh, it's going to be a mess because it's just the level of machine learning required for coding is not there yet because it's a lot of moving parts. When you're coding a case, it could be easily 50 guidelines that are swirling around at the
Hmm.
same time in relation to that case, and you have to know how to keep track of all of it. And at this current level, machine learning is not there yet
Yeah.
because I've seen like even because they even will code some procedures, and procedures are complex, and it's like
Hmm.
some of them it's like they don't even try. It's like I don't even know what that is, and then sometimes they give you sometimes like for instance, but that's also very basic like cardiac catheterization. That's pretty standard,
Hmm.
you know. So it's spot on with that,
Hmm.
but when you get into other complex procedures, it has no clue. It can't even it doesn't even offer anything.
Yeah, and I'm
But
thinking, even with surgeries, to your point, yeah, there may be some, you know, basic surgery procedures or with the opno, generalized documentation, but a lot of them, you don't know what you're gonna know until you open that body up, and then things in the game then change, and so yeah, again, I don't. I think I just don't think that people are taking the whole process into account or into consideration.
well, the reason why I don't think they are is because I think that people think that AI is better than they are, and it's not. I really think that that's the whole misconception. People think that computers are inherently better, quicker, and faster, and they're not.
Mm-mm.
Because who built the computer? And that is like because case in point, like what's getting ready to happen, and I see it just as plain as day. What is getting ready to happen in HIM, not necessarily right away, but what I see coming is now the thing is like they're starting to use AI for queries.
Really?
Yes. And they're starting to have these basically you're just going to be able to like click. We just had a training this week and it all sounds good till it doesn't work. And they're you're going to be able to just like click boxes and a query will be written up and sent to the provider. But there was no there was no mention of validation. There was no mention of what do you do when you have conflicting documentation. None of that. It's too perfect world, and they try to sell it like it's perfect world until the real world applications happen, and then it falls flat.
Right. Yeah, like I said, garbage in, garbage out. AI is only as smart as the information entered into it. Yes. And the more detailed the information, the better outcome. You're right. I mean, we demonstrated that just last week. Oh, that's interesting how they are moving to do that. And then, I mean, oh my God. We humans are still having problems with putting together or determining and deciding when to query. So
And then when you reduce things to a couple of clicks, and then something pulls it all together, the end game of all that is that then anybody can do it. Because that's really where it's going. Like towards the when in this final iteration, there's going to be no need for coding anything, because AI is going to be the machine that puts it all together, and you'll just have some people that have some cursory knowledge of some things, and they're just going to just be overseeing the and clicking, and then that's going to be that. Like there's not going to be it's going to be very few people to have the high level discussions or to the high level deeper dives that are necessary, because everybody else is going to be in the Philippines or Peru doing this.
And so, putting on my compliance hat, I wonder how these payers or we'll stick with the payers. How the payers are they jumping into this AI for their work? I don't know. I don't think so. So now you're gonna have the regulators checking for, or the payers checking this AI generated claim, if you will, and based on potentially AI generated documentation, because that's another thing that they're selling to these physicians. Oh, we can generate, based on this, that, and third, we can generate everything, all the documents. I just are they also looking to then have an AI generate the review, or the AI generate, the criteria for audits, or all of that? I'm just wondering, like, where does it all end with the people? And all I could think of is, like, if they don't, so say a human is the person auditing all of this AI generated claim and documentation, and the amount of things that could potentially be wrong, because again, what you put in it. So say, and we know this today, you have rules or regs that have changed, or guidance that have changed, and no one has told the people who are coding in that particular area that this has changed, and so they're operating is business as usual. But ultimately they are responsible, because they should have known that these things are changed. So they have put into their AI algorithms or whatever outdated or misinformation, which now causes all of the stuff to be wrong.
Well, I think that's really something key right there, because what I'm trying to understand, and I've seen this happen in how many coders, how many HIM professionals that really know coding are at the table with these developers. How many? I would venture to say not many, if any.
Mm-hmm.
And it's, we're the ones impacted, but we're not involved in the process. What does, I don't care how well you program, what do you know about coding and coding guidelines? Nothing. What do you know
Mm-hmm.
about combination codes? Nothing. For instance, in 3M right now, if somebody has any type of diabetes and they have unspecified diabetes, unspecified chronic kidney disease, according to the tabular index, you cannot link diabetes and unspecified CKD. It has to be a stage.
Mm-hmm.
But AI will auto suggest E1122. It does, and you can do it.
And so somebody
So
who doesn't know the rule or the guidelines related to
we'll
that
just click it.
would take that suggestion and go.
Hmm.
And woo, this is out of my queue.
But that right there shows how uninvolved HRM professionals are in this process, because an HRM professional would have been like, oh no, you can't do
Would
that.
not even put that in there. There shouldn't even be an
Exactly.
option. There shouldn't be something that um or or no, they shouldn't put that. It shouldn't even be an option. I was about to say,
But right, but that's a programming issue. The
uh-huh.
people who program that need to have more of a loop
Mm-hmm.
in their programming when they go to assign those N18 codes. If it's N18.9, then you don't. It should be an if then else, and it doesn't need to be in that E11. It shouldn't be a 0.22 with that. But that's a programming issue. But they don't know not to program because the people who know it aren't involved in the process.
Right. And if it's just, and that's been around, 3M has been around for many, 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 many years. And no one has thought to correct that. So imagine, someone new to this game not understanding or even combining what is already not programmed appropriately with the overarching on a 3M process or program, then creating even more errors downstream.
Mm-hmm.
Mm-mm-mm. Wow. Interesting. Yeah, yeah. So that was we are at the top of the hour. That was pretty much what I wanted to bring for you today. Our discussion about AI and health information, how folks are considering moving forward with some of these technologies and tools, possibly with the exclusion of health information professionals at the table, not necessarily understanding or taking into account the full revenue cycle and its impacts on all areas of the cycle. Um, yeah, more to come. While folks is jumping at the bit, ready to pounce and whatever. I hope they stack in their paper. How about that? Because on the back end, when those fines and stuff comes and hit, I hope the paper is stacked as well. So wherever the savings is, just make sure you hold on to those savings that you think you're gonna get, because yeah, they're gonna hit. That I see. I see that as well. Yes, lazy work equals incompetence. You are absolutely correct. You are absolutely correct. All right, y'all. Well, this was good. This was good. Thank you all for joining the Saturday morning tea or checking out the replay. Was the tea spilled today? Was the tea spilled today?
Absolutely.
Yes. If this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Also, we will be having our meeting after the meeting. If for more information, check out the description box for our Patreon information so that you too can be part of the meeting after the meeting.
I,
Also, yes, sir.
I just want to jump in. The meeting after the meeting today is going to be juicy. I have some info.
Oh, I love it when it's juicy. Yes, yes. All right, y'all. You heard it from Mr. Jesse's mouth. Juicy info. Come on. So be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. As you leave out, please don't forget to hit the thumbs up or like button, and also check out the Coding Nurse channel on YouTube, where he drops gems as well. Again, this has been a great session today. Thank you for joining. We will start the meeting after the meeting at 10:15. So for those who are members of our Patreon, you know, you already received the information. So thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care.